All right. So I've been asked to sort of link mechanism with clinical findings, so I'll try and bring you back to the clinical arena as we go through some of the basic mechanisms, but you can't discuss one without the other. So as long as there have been cardiologists, touched on it earlier, that if a patient has a heart attack on the day that they also had angina, they tended to do better. And at least qualitatively, those patients tended to survive better, and the impression was that they had smaller myocardial infarctions. Now, that was a clinical impression 20, 30 years ago, and over the last 10 years, with the advent of transcatheter interventions, we've been able to test that theory, and these large-scale interventional studies have allowed us to show for sure, scientifically, statistically, that if you have angina on the day that you have your heart attack, subsequently undergo a balloon angioplasty, your myocardial infarction is generally speaking smaller, and your outcome in terms of survival and heart failure-free survival is better. So there's something about having angina that protects you in the long term. Now, 30 years ago, when Chuck Murray was investigating this impression, of course, we didn't know whether that was a biologic signal or whether it was an epiphenomenon, because patients who had angina just had a different type of coronary disease and so had a better outcome. So he tested it directly, and you're all aware of this data now. Took dogs, preconditioned their left anterior descending coronary artery by occluding it for 4 occasions by 5 minutes, subsequently rendered that territory with a potentially lethal myocardial infarction, and showed a fantastic reduction in myocardial infarction size. This was one of the keynote papers in our field, certainly one of the most quoted papers in cardiology. And despite 5,000 or more subsequent publications, unfortunately, local preconditioning really failed to make any clinical traction, as we've heard about all day now. It's very difficult to predict a myocardial infarction. It's very difficult to precondition the myocardium in any case. And so it sat there as a very, very interesting biologic phenomenon about which we learned a huge amount, some of which Jim told you about in the last lecture in terms of mechanisms, but one that we really couldn't use clinically. Now, the game changer was Karen Schecklenk. She showed, in fact, she's currently in Cincinnati. She's a visiting professor at our institution, so couldn't come here this time. She apologizes. But she showed that you could precondition the circumflex coronary artery, render the left anterior descending coronary artery ischemic, and subsequently reduce the myocardial infarction size in that remote territory. And this idea of preconditioning at a distance was established. And then over the next 10 years or so, the distances got bigger. So in rodent models, for example, you could precondition the mesentery and reduce the size of a myocardial infarction, or precondition the kidney and reduce the size of a myocardial infarction. Again, all very interesting biology, real, I think, test cases in terms of what we might potentially achieve, but not particularly relevant from a clinician's point of view. So I was lucky to have a research fellow, Raj Gobanda, who was working with us in London at the time. And what we did is decide that the limb was a potentially organ-specific driver of this remote preconditioning stimulus. Whether it's skeletal muscle, whether it's the skin, I don't actually know. But nonetheless, by rendering the arm or the leg transiently ischemic, we were able to show in a pig model that you can reduce the myocardial infarction size by about 50%. And that was really where this whole field took off, I think. We had a clinically relevant stimulus that may or may not make a difference to our patients. So first and foremost, in terms of the clinical applications, as Jim said, until we know mechanisms, we don't really have any answers. What is the mechanism of remote preconditioning? And very briefly, we could spend an hour talking about this actually. There are essentially 2 divergent, potentially, hypotheses, which I'm going to try and convince you that actually come together. There's the neural hypothesis, that is you have to have some neural connection between the arm and the heart, or the mesentery and the heart, in order to transfer the stimulus. Or the humoral mechanism, that is there's something in the blood that is bathing the heart that's released from the kidney or the arm or somewhere that produces that cardioprotective effect. The reality is it is both, and I'm going to show you evidence for both. They are inextricably linked. So this is the evidence for a humoral effect. This is work from my lab in Toronto at this time by Mikiko Shimizu. Essentially what she did was precondition rabbits, take their blood, run the plasma through a Langendorf, and we were able to show that that plasma produced cardioprotection. If you dialyze the plasma, that is, you take everything under 15 kDa and run that through a Langendorf, you get that same level of cardioprotection. And if you run the dialysate over a C18 column, so you take up all the hydrophobic molecules, elute that column, so now you've got molecules that are under 15 kDa but are hydrophobic, that is also potently cardioprotective. And to exclude the influence of neurons within the myocardium, absolutely, if you take fresh isolated cardiomyocytes, put the dialysate on those cardiomyocytes, you get the same level of cardioprotection as you would see in ischemic preconditioning. So there is undoubtedly a circulating effectors that generate this preconditioning effect. And if I precondition myself or the people in my room, in my research room, take their dialysate, run it over a rabbit Langendorf, we can reduce the myocardial infarction size in that rabbit Langendorf by about 50%. This seems to be a conserved mechanism for interspecies transfer. Now, you can't get away from the nerves, though. Now, in the arm or the leg that is being preconditioned, if you cut the nerve that supplies the leg, in this case we transected the femoral nerve, you abolish the release of that cardioprotective substance or substances into the plasma. So the dialysate is no longer cardioprotective if you transect the femoral nerve before you apply the transient ischemia to the leg, in this case of a rabbit. And in a heinous piece of nepotism, this is work that my daughter did, if you stimulate the nerve or you stimulate the sensory nerves in the skin of that rabbit's leg, you render their plasma cardioprotective just in the same way as transient ischemia will do. That suggests that there is an upstream neural mechanism within the limb that is related to the release of cardioprotective substances into the blood, and it's that blood then that provides the multi-organ, not just obviously cardioprotection, that we see with remote preconditioning. And the clinical correlate of that, just to bring you back, this is a beautiful study done in Denmark. This is looking now at humans with and without diabetic neuropathy. Diabetics without neuropathy, when they're preconditioned, have plasma that is cardioprotective in this case, a mouse Langendorf. If they have neuropathy, their plasma is not cardioprotective. So there is a clinical correlate, and so we can anticipate, for example, that remote preconditioning with a blood pressure cuff will not work in a diabetic with neuropathy. Over the years, we've learned a lot about remote preconditioning, and I'm going to go through it very, very quickly. Suffice it to say, and I'm going to go through these slides very quickly, remote preconditioning seems to induce an identical portfolio of kinase changes within the myocardium and most cells as we saw with ischemic preconditioning that was locally initiated. So PI3K AKT pathways, PKC epsilon translocating to the particulate fraction, all of these things were shown early on in my lab and are essentially identical to a local preconditioning portfolio, and I'm not going to beat that one to death. Now, as you look at the field of preconditioning, and as I prefaced, if it was just that, then we would expect the results of our intervention, blowing up a blood pressure cuff on the arm, to render the patients just as well preconditioned as, for example, giving them adenosine or giving them nitrates or bradykinin or all the other drugs that have been given to patients undergoing myocardial infarction, all of which have been stone negative in terms of their clinical effect. And there is evidence to suggest that remote preconditioning isn't stone negative. There does seem to be a biologic signal, and it rather suggests, therefore, that remote preconditioning does more than just induce a cytoprotective phenotype. It may be more biologically inclusive. So, how could it be more biologically inclusive? Well, we know that to fully understand the effects of myocardial infarction, obviously we need to know what happens during ischemia reperfusion injury. But that is a very, very complex mechanism that not only is modified by inherent cytoprotection, but can be modified by other factors. So to have a reperfusion injury in its total, you not only have to have a protected a myocardium that is susceptible to injury, an unprotected myocardium, but you have to have an inflamed endothelium, you have to have activated platelets, and you have to have angry neutrophils. And if you block any of those parts of the cascade, you reduce reperfusion injury quite significantly. In fact, in a non-preconditioned myocardium, if you take the neutrophils away, you essentially reduce myocardial infarction by about 20%. If you take away the endothelial dysfunction induced by that, you further reduce myocardial infarction. And there's good evidence that this biologic stimulus, this, if you like, clinical stimulus, has rather broad effects, rather pleiotropic effects at a biologic level. So one of the first things we found in one of our studies was that when we preconditioned animals, their coronary blood flow increased, just as a result of preconditioning itself. So a normal animal, preconditioned, coronary vasodilation occurs, almost as if it's preparing the heart for something bad to happen. And other studies have shown that, for example, as you're being preconditioned on one arm, there is increased blood flow to the other arm. And we know from many, many studies now that remote preconditioning is a very powerful tool to protect against endothelial dysfunction as a result of ischemia. So it preserves your endothelium not just in the arm that's being preconditioned. One of the first studies that Raj Kharbanda did was to show that the contralateral arm was protected against prolonged ischemia in terms of endothelial dysfunction, and now we know that every vessel in the body that has been studied is similarly protected. This is, for example, a study of remote preconditioning in the coronary microcirculation of patients with heart failure. Really quite a marked effect. The worse your endothelial dysfunction, the better the effect of remote preconditioning in terms of restoring some flow-mediated dilatation in response to transient ischemia. What about the platelets? Well, transient ischemia of any of your organs, any part of your body, will stimulate your circulating platelets to become angry and sticky. Remote preconditioning has been shown in 2 very good papers to reduce that hypoxia-induced stickiness that could be related to subsequent thrombus formation and endothelial activation. But this is where I think perhaps most of the money lies. This is work from my lab. A fellow called Igor Konstantinov did this study of human neutrophils, whereby initially we looked at gene responses within human neutrophils simply as a result of preconditioning ourselves with a blood pressure cuff and a stopwatch. And every gene that is labeled here in green is a gene that is down-regulated by remote preconditioning in your or my neutrophils. And if you play that game, there's a huge amount of redundancy, as you know, in the neutrophil in terms of pro-inflammatory pathways. You can get from stimulus to release of cytokines via multiple different mechanisms. You can see that if you play that children's game now, you can hardly get from one side to, if you like, activation without passing through a green gene, a down-regulated gene. It's a very highly effective anti-inflammatory process, which was touched on a little earlier today. That has an effect in terms of neutrophil adhesion. It essentially turns off neutrophil adhesion. This is a simple experiment looking at human neutrophils and how they stick to a Petri dish. So this is now functional analysis of those gene regulatory effects that we saw in that previous paper. A very profound effect that is really rather resistant to tachyphylaxis. You can see still after 10 days of consecutive preconditioning, the neutrophil function is markedly downregulated. I'm not going to show you the data, but Dr. Gidesh did show it to you. Phagocytosis, which you might consider to be a rather beneficial effect of the neutrophil under these circumstances, is also downregulated. We do have to ask the question, I'm going to ask it later, what is the downside of preconditioning? There must be one, otherwise we'd all be preconditioned all the time. So all of that's well and good. All of those studies I've shown you is with a preconditioning stimulus. That is, you're delivering it before the onset of ischemia, and there seem to be some really rather profound effects. So in around about 2004, we asked the question as to whether if you provided the transient ischemia of a limb during ischemia but prior to reperfusion, do you get the same effects? And Michael Schmidt, a fellow of mine at the time, did that study, and I can tell you very briefly after 2 years of work that essentially it recapitulates remote preconditioning when it's delivered before the ischemic hit. So you get all of the benefits even though the coronary artery, for example, is already occluded. And the idea of this per-conditioning stimulus that has potential clinical relevance for evolving ischemic syndromes like myocardial infarction was established. Now, our LeDuc funded group in Denmark then set about this study, the Condi trial, whereby we took 300 Danish men and women in the back of an ambulance, randomized them to receive preconditioning with a blood pressure cuff and a stopwatch prior to their transfer on the way to the catheter lab in one of 3 centers in Denmark where they underwent balloon angioplasty and stenting for their evolving myocardial infarction. And the results were better than we could ever have imagined. Now, I will emphasize also in view of Jim's talk, every single one of these patients received clopidogrel as part of their induction therapy prior to balloon angioplasty. So this is looking as though it's going to have an effect over and above that clopidogrel blocking effect that we've seen in post-conditioning. The salvage was increased by about 20%, which is quite extraordinary. This was with SPECT analysis, and the larger the infarct, just like you saw in the post-conditioning trials, the more effect that you saw. And for those widowmaker infarcts, the LAD infarcts, there was a reduction in LV loss from about 17% of the total myocardial left ventricular volume down to about 6%, a reduction by about 2/3, way beyond what we'd ever calculated for, beyond our wildest dreams in a sense. We're not the only ones. I think it's fair to say that every single study that is used per conditioning at the time of myocardial infarction with balloon angioplasty and with thrombolysis in a study done in the Far East have shown a positive benefit, at least biologic benefit, in terms of either a troponin release, a CPK release, or under most circumstances some supplementary evidence of myocardial salvage or infarct size. So we are awaiting now 2 very large, I would say, phase 3 trials involving thousands of patients, which will report in about 12 to 18 months. That's going to be the make or break time. If that's negative, we're done. I suspect that will be the end of remote preconditioning for myocardial infarction. If it's positive, I could only imagine that it will go into clinical practice. And some places are already using it as part of their clinical protocol, rightly or wrongly. This is a summary slide. It's a few years old now, but it's a lovely slide. It sort of makes the point that Jim was making, though. This is looking at, and you won't be able to read it, of course, all of the cardiac-related remote preconditioning trials or per-conditioning trials at the time, with the vast majority of them shown here, if I can make the pointer work, showing a positive clinical benefit, but with some very notable exceptions, and particularly in the field of cardiac surgery. And there have been 2 blockbuster cardiac surgical trials, both of which were neutral, published in the New England Journal of Medicine just a few months ago, which has essentially killed the field in terms of cardiac surgical intervention with these conditioning strategies. Rightly or wrongly, there are methodologic issues, the use of propofol, for example, that may block the preconditioning stimulus. But I suspect, having done a multi-thousand trial, nobody's going to have the stomach to reproduce it. So we're really focusing on those areas that are most relevant actually to the areas that have been studied best in animals, and that is a ischemia reperfusion model within the myocardium at the time of evolving myocardial infarction. Although there are many, many other areas we could spend all day talking about the effects on contrast-induced nephropathy. We're going to hear about its effects in stroke, for example. but there seem to be more effects than one might anticipate from a purely cytoprotective mechanism. The long-term results of our first trial are looking very encouraging. Of course, that's what you'd expect if you get an upfront benefit in terms of infarct size. You'd expect a downstream benefit in terms of all-cause and cardiovascular mortality and MACE rate. And at 5 years, there was a significant reduction in both of those things in the preconditioned group. So the benefit that we see, obviously, it's all very well reducing infarct size. If the patient still died, it wouldn't make much difference. But you can see there that there are still significant numbers of patients that, despite having optimal cardiac therapy, are suffering from late consequences, including death and heart failure, for example. And this is a slide that really shows a rather depressing Kaplan-Meier curve. Most Kaplan-Meier curves that show era effects get better with more recent era. And this is showing exactly the opposite. Survival, free of congestive heart failure, is getting worse with every cohort, with every more recent 10-year period. Why is that? Well, our patients are a victim of our own success. Fewer patients are dying at the time of myocardial infarction, but they're surviving with congestive heart failure. So we asked the question, and again, you've seen this data, so I'm going to go through it fairly quickly, as to whether if we continue to give the remote preconditioning or the remote conditioning stimulus after a myocardial infarction, because we know that that heart failure phenotype, the remodeling phenotype, is essentially driven by the degree of inflammation within the myocardium, and that is somewhat idiosyncratic. Whether by suppressing neutrophils, macrophages, improving endothelial function, improving coronary blood flow, we might modify that heart failure phenotype. So we took a lot of rats and we subjected them, as you saw earlier, to a dose response in terms of the preconditioning intervention. And again, very briefly, the more preconditioning you get day by day after a myocardial infarction, the better your heart works at 28 days. And that seems to be related to modifying the intrinsic inflammatory response within the myocardium. So macrophage numbers, any measure of the inflammatory process within the myocardium was all significantly downregulated and in a dose-response manner according to how many episodes of the preconditioning or the conditioning stimulus you had. And the animals that did best were the ones that were preconditioned every day for 28 days. Now again, that would be useless if by 28 days we saw all these beneficial effects, but then when we stopped the conditioning stimulus, the animals then developed a heart failure phenotype and died. And you saw this Kaplan-Meier curve. This is now taking the animals out to 12 weeks, looking at the potential benefit in survival. This was a massive study. I can tell you a funny story about it. 50 rats in each treatment group. It was an enormous amount of work being done. And suffice it to say that if you're preconditioned every day for 28 days and then you stop the preconditioning and take these animals out to a 3-month survival period, their survival is highly significantly better than other groups and much, much better than shams, of course. Why is that? What's the mechanism behind the reduced inflammatory response? Well, some of it's primary, as I mentioned, I think, because it does affect the circulating monocyte directly, but it also seems to be within the myocardium itself. I am developing quite a strong interest in autophagy as a protective mechanism, not just in the heart, but I think it's a powerful protective mechanism in all organs. The more autophagy we have, the better we tend to do. Autophagy signaling in remote preconditioning, when delivered day by day over a 10-day period, induces a broad portfolio of autophagy stimulating effects. mTOR is reduced, which is a negative regulator of autophagy, and all throughout the autophagocytic apparatus there is upregulation of proteins that are potentially beneficial to a myocardium that is damaged and needs to clean itself up. And this pro-autophagy signaling, I think, will be quite an important area in the preconditioning field in general. So, in the last 5 minutes, how can all of these things happen with a single stimulus? We blow a balloon up and something is liberated into the blood, and yet we see multiple effects. It's difficult to imagine, and I don't think I know the whole answer, and I suspect it may well be that when you blow a balloon up on the arm, multiple things are liberated from the arm, and they all have their own role to play in this phenotype. But because there are some things, like transcription factors or microRNAs, for example, that are master regulators of multiple pathways, we got interested in microRNAs as a potential mechanism by which this effect could be at least curated. So we did a microRNA array and found around about 20 or 30 microRNAs were upregulated as a result of preconditioning within the myocardium. But most importantly, there was only one microRNA that was massively downregulated as a result of ischemia. So we looked at the effects of preconditioning, we also looked at the effects of ischemia. And microRNA 144 is completely abolished by even relatively short periods of ischemia within the myocardium. So it seemed like a good target to look at. Could it be that microRNA 144 has some role to play either in the preconditioning stimulus or cardioprotection in general? And so we looked at it. This is again summarizing 2 or 3 years' work in a couple of slides, and there's much more behind this, of course. But this slide really tells the story. If you give microRNA 144 to an animal by a tail vein injection, you get major cardioprotection, similar cardioprotection to that seen with remote preconditioning. And if you block either preconditioning or MIR144 with a specific antagomer to 144, you block the cardioprotective effect. That's not to say that it's the be-all and end-all of cardioprotection because of remote preconditioning, because you can block cardioprotection of all conditioning strategies with any number of single-site blockers, but nonetheless suggest there may be some role at least. And certainly as a potential therapy, microRNA has some effects. The good news is that if you precondition a mouse, you get a 2 or 3-fold increase in circulating MIR levels, and if you precondition you or me, you get a similar level of increase in MIR144. So it fulfills the putative requirements for a circulating effector of remote preconditioning. I guarantee you that it isn't the circulating effector of preconditioning because it doesn't do everything, and I don't have enough time to tell you why. It is a rather interesting drug, though. You can inject MIR144 into the bloodstream, and it doesn't get eaten up by circulating RNAs. It binds to Argo2 and circulates in the blood, and then gets distributed around the body. Interestingly, if you inject it into the blood, you can see a temporal pattern that's not dissimilar to what we see with preconditioning, a peak, a sustained level for about 7 days, and then a falling off over a 2 to 3 week period. And there are some really interesting phenomena that we're seeing. We discussed earlier this idea that a little bit of what you need can induce more of what you need. This is what we saw in the liver. We labelled the injected MIR144 with CY3. We were able to see this temporal pattern within the liver where it dissipated over the course of a week or two. But look what happens in endogenous MIR144 levels. Injecting MIR144 increased and showed a continued increase in MIR144 levels within the liver for fully 28 days after the injection, well after the labelled MIR144 has disappeared, suggesting that it's inducing endogenous release of MIR144, potentially sustaining the beneficial effects of preconditioning if it's inherently involved. Finally, in the last 2 minutes, so we've got 5 minutes of questions. What's the downside? I'll say it again. If it's this good, we should be preconditioned all the time. So there must be a downside to being preconditioned. Otherwise, we would be preconditioned all the time. So we have to be cautious about inducing it willy-nilly. Otherwise, we could actually be doing damage to our patients in the long term. And then the second question is, God didn't know we were going to develop blood pressure cuffs and a stopwatch. So what is the natural stimulus of preconditioning, of what is the remote stimulus that provides us with that potential benefit? Again, I don't know the answer to either of those questions, but I can give you a few clues. If you take Danish medical students and you exercise them, if you run them, and then take their blood after they've run, compare it with the blood before they've run, their post-run blood is cardioprotective and has the exact attributes. You can dialyze it, you can run it over a C18 column, has the exact attributes of a remotely preconditioned patient that you've put a blood pressure cuff around the arm. So exercise certainly appears to be, and this has to be very vigorous exercise, a preconditioning stimulus. And the converse, just for fun, is that if you take elite athletes who are essentially limited by lack of enough blood, certainly they've got more blood than we could ever imagine going to our muscles, but lack of enough blood to allow them to continue to exercise, it's a relative hypoxia or ischemia. You can make elite athletes exercise better by remotely preconditioning them beforehand. A paradox there that they may be preconditioning themselves but also preconditionable, which also begs the question as to whether it might work in some of our patients. And it turns out that, as we've been discussing all day, you can sometimes have too much of a good thing. This is what happens in patients with heart failure. They are limited by the lack of blood flow to their muscles, just as an elite athlete is, but just at a very earlier level. And so we thought maybe preconditioning would help them. And the fact of the matter is several of our patients had a worsening of their exercise performance as a result of our preconditioning intervention. The good news is that some of them got better. The bad news is we didn't predict beforehand which ones were going to be improved or get worse as a result of preconditioning. It turned out, and we were very lucky, we took blood from each of these individuals and we dialyzed that blood and we looked at the preconditioning cardioprotective activity of their blood. And if you were already cardioprotective and you delivered an additional dose of preconditioning, their exercise function got worse. And if they weren't cardioprotective and you gave them that extra jolt, their exercise performance got better. We were able to differentiate between the two, but it does also emphasize the fact that too much of a good thing can sometimes be a bad thing. So in conclusion, I hope I've convinced you that remote ischemic conditioning, which is probably what we should call it because it's pre, per and post, modifies the myocardium in classical cardioprotective ways, but appears to have pleiotropic effects across the board in terms of the way in which you might want to modify reperfusion injury. There are positive and negative trials in just about every field where it has been applied. So far so good for evolving myocardial infarction, but until we have long-term data and large-scale trials, it has to remain experimental. Thank you very much. Jim?
Going back to mechanism, clearly the neutrophil seems to be sort of your focus for the protective mechanism of the remote. And notice that you can ischemically precondition a Krebs perfused heart, which is neutrophil free.
Sure.
Again, showing that those are very different mechanisms.
As you know, though, the amount of cardioprotection you get in an isolated heart tends to be less than you get in an in vivo preparation.
Well, I wouldn't say that. The data I showed there where we had about 2/3 reduction in infarct size, those were all Krebs perfused.
Oh, I understand that. It depends on the model that you're looking at. But if you add remote preconditioning in vivo, you get a significantly increased myocardial protective effect if you look at area at risk compared with an in vitro mechanism. Now, there's no doubt in some models you can virtually reduce infarct size to zero in an isolated preparation. But in terms of a single model like remote preconditioning, the other potential effect is that, of course, we're not seeing the downstream effects. We reperfuse for 2 hours, kill the animal and measure the infarct size. that's not myocardial infarction. We're not looking at what might be occurring during the next 6 and 12, 24, 28 days. And so I think some of those other long-term effects are completely missed and lost in isolated preparations. Sorry, I had a question.
Well, we've got all these people who are at risk of myocardial infarction, and we're giving them truckloads of drugs for preventing it. If you were predicting what would be a way of preconditioning them, and how would you pick them, and what methods would you use?
That's a big question. I think one of the reasons that we are seeing failure of translation of some of these things is that we do have patients with a truckload of comorbidities that all may affect the ability to be preconditioned, including aging, but coexisting diabetes, hyperlipidemia, all those things. And we also give them a truckload of drugs that may either be blocking preconditioning, things like anti-diabetic therapies, for example, or maybe preconditioning themselves, like ACE inhibitors or beta blockers. And so when you translate this into the wild-type human, I think that's why we don't see these massive benefits that you can see in an isolated heart or a young juvenile mouse or something. Nonetheless, that's true of everything we do now for myocardial infarction. Doesn't mean to say we shouldn't study it. If we were able to get a 5% benefit, that would be an intervention that might be worthwhile, particularly when a blood pressure cuff and a stopwatch cost nothing, or one of these commercially available devices costs $50 or $100. The return on investment by comparison to some of these very expensive drugs or stem cell therapies, for example, is massive. So I do think it's worth potentially thinking about it as a therapeutic tool. What I thought you might be mentioning is whether you would suggest that everybody be preconditioned every day. Why not just blow a blood pressure cuff on your arm every morning when you're having breakfast? If it stopped me having to go to the gym and exercise, I'd do it in a heartbeat. And jokes aside, there are some people that can't exercise, right? You have a physical disability or whatever. Maybe for those, this is a surrogate, a replacement for exercise.
Are there many people today using it as a replacement for exercise? As a public health?
I don't know, and I hope not. You know, what I do know is a lot of athletes are doing it because there are multiple studies now, rowers, 5K runners, showing that you precondition yourself, you get around about 2 to 3% benefit in terms of maximal performance, which for an elite athlete or an enthusiastic amateur, that can take 30 seconds off a 5K run, and then suddenly they've done the best time ever. So people are doing it. The worry is that people might end up doing it too much, and then we start to see what must be an inevitable downside to be preconditioned too much. Maybe too much exercise, if it is a preconditioning stimulus, is what we're seeing in terms of what Carl showed us. There's a sort of dose response, and then you start to get worse as a result of having too much. So I wouldn't want people to be using it indiscriminately, that's for sure. Question?
Yeah. Are you suggesting the following, which I sort of picked up on, but and may not be correct, that a person who exercises appropriately, that is not too much within a certain hormetic window, is likely to have little additional benefit as far as ischemic perfusion injury is concerned from blood pressure constriction.
I think that's probably right. Or if they had angina that day, because they probably preconditioned themselves. The fact of the matter is that most people are about to have an infarct and not running vigorously the day of or the day before. Sometimes they're during it, but not before. They tend to be more sedentary, and that's why they end up having the infarct. So we're not dealing with often a preconditioned phenotype. But yes, I am saying that. I think there are endogenous ways in which you're preconditioning yourself every day, and that would obviate the benefit of having a blood pressure cuff stuck on your arm. One final question.
I wonder what your thoughts are about FMD, flow-mediated irritation, which is generally regarded as a sort of health marker for vascular health effects.
So there are multiple studies looking at FMD and remote preconditioning. One of your countrymen, Dick Tyson in Leiden, has now looked at normal volunteers and given them daily remote preconditioning, and gets a I can't remember what it was called this morning, a supranormal effect. That is, they're all normal, right? But if you precondition yourself every day, your FMD goes up by about 3%, not 3% of the base, but 3%, which is actually a massive increase in FMD in terms of response. So it does seem to have benefits in health. Now, these were young, healthy volunteers, but they were not regular sports people. They weren't exercising regularly. Whether, to come back to the previous question, if you did the same experiment in young, healthy volunteers that were running every day, which we know improves FMD, I don't know.